what I need to do is I need to introduce our runners and riders here. I feel it's a bit like an F1 team, isn't it, where all the F1 drivers are lined up and they go, oh God, we've got to speak to all of our partners. But there they are, and I'll introduce them as we go. So we've got Fiona. She doesn't really require an introduction. As Natalie's sister, she obviously started with Trust. It was 12 weeks ago, so as long as that. And is director of the Trust. Now we've got Professor Stuart Allan, Professor of Neuroscience and Faculty of Life Sciences at Manchester University, and he's going to give us a bit of the story thus far. We've then got Dr. Katie Murray, who's here to my right. She's a neuroscience researcher, and I think she did spend 7.5 years at Yale. Is that right? Yes. And then she was sort of scooped up by NKMT through their funding. Has been working as a research fellow. She's going to explain a little bit about the work she's been doing thus far. We then have Adrian Parry-Jones. He's a professor of vascular neurology, and he's going to talk to us about the challenges of treatment and treating hemorrhage, and the work that he's been doing on that issue. And then what we're going to do is we're going to look to the future. We're going to have a think about prevention and in particular blood pressure, so we're going to focus on hypertension. And Alan Greenstein is going to help us with that. He's a clinical scientist at Manchester University. He works as part of an internationally renowned hypertension service. And if you look on the internet, he's probably got, I think it was you, probably got the best quote. Because if you look on the internet, everybody's got a quote, sort of sums them up. And his is, cook slow, chew thoughtfully, and jog gently. that is now to be my mantra. All right, okay. So, as I say, we've only got 45 minutes. So, without any further ado, can you Fiona just start us off, please, and just quickly explain how we've all ended up here this morning and why we've got this is the panel and these are our partners.
Yeah, absolutely. Firstly, thank you very much to Andrew for supporting us today, and obviously the rest of the panel as well. And thank you to you guys for joining. So, you all, I'm sure I've sat on a Zoom call with most of you and explained the story of the Natalie Moss Trust, but to very quickly rewind, obviously, as Andrew mentioned, we set up the Trust in 2012 after my sister Natalie had a brain hemorrhage at 26 in 2011. We obviously wanted to do something positive in a very devastating situation. So we reached out to Stuart to see if there was anything we could support at that point. There really wasn't much research around brain hemorrhage at that time. But over the last 12 years, that's significantly changed. And it's changed dramatically that now you have over 25 researchers in the team. There's obviously major developments in the research that's rolled out to the NHS, which Adrian will share with you in a little bit. But I think the key point of why we're here today is really to share with you more about this work, more about the developments, more about the importance of why this work is so incredibly vital, because brain hemorrhages are immensely devastating, but also extremely common as well. And this research is critical. It really, really is critical in order to change the direction and the landscape of brain hemorrhages as well. And as we move forward with the Trust as well, the work around prevention is so key. We'll come on to that a little bit later as well.
Okay.
So, yeah.
So Fiona, what we'll do is we'll come back to you if it's all right. It's about halfway through. You explain where we are and where we're going. But you were talking about the 25 researchers that have been involved in this project, and in particular, Stuart, could you just give us a little bit more flesh on those bones? So, and in particular, reference to the Geoffrey Jefferson Brain Research Group. So, if you just help us with that.
Happy to do that. So, when the family approached us back in 2012, neuroscience research in Manchester was very fragmented, I would say. So there was a lot of people doing bits here and there. So lots of discovery science, basic science at the university, including people at our own group working on stroke, mainly ischemic stroke, which is a clot rather than a bleed. And there was bits and pieces round about the place. And there's a very good clinical service across the Salford Royal, which Adrian is based at. And Manchester has, which many people probably don't realise, Manchester has the biggest neuroscience centre in terms of clinical, probably in Europe. So there's only one neuroscience centre for the whole of Greater Manchester. So if you have a neurological condition, which includes stroke, you will go through Salford Royal, no other hospital. And that's very unusual to have one centre that takes every patient. So that's about 3.2 million population. So about 6 years ago, myself and Andy King, who's a neurosurgeon, and several people at the university discussed this, and I thought, we're missing a trick here. We're not capitalising on the strengths we've got in terms of the hospital and the university. So we felt we needed to create a brand, if you like. And it's similar to how the Kate Moss has developed the brand. And then we created the Brain Research Centre. Rather than just call ourselves Neuroscience Manchester, we created a thing called the Geoffrey Jefferson Brain Research Centre. Geoffrey Jefferson was actually a professor, the first ever professor of neurosurgery in the UK back in the 1920s. He trained in Manchester. He was very a Manchester story. He actually went on, as well as doing neurosurgery, he worked with Alan Turing on AI back in the 50s, believe it or not. So he was an incredible individual who we felt was appropriate to honour in terms of naming the centre. There is no physical centre, so that's my dream. The dream is to raise enough money to build a state-of-the-art neuroscience hospital, to be honest. It's a research centre. But that was really the focus, to bring it together and to focus on a few key areas. A major one being stroke. So we have a major interest in ischemic stroke, particularly, and that had been running for many years. So Nancy Rothwell, who some of you know the name, Nancy was the president of the university, just retired this summer. She set up the group that I now lead. She set it up in the early 90s. And the focus was completely on ischemic stroke, on inflammation and how that contributes towards a stroke caused by a clot. And then that, until we were approached by the family, we didn't work on haemorrhage very much at all. Adrian was beginning to develop some work, but we had no real focus in that area, and that changed dramatically through the engagement with the trust and bringing PhD students on board, and then just building more and more. And as we say now, there's a large group. In fact, more people now work on haemorrhage than ischemic stroke within the group. So that was the story, and then the Geoffrey Jefferson focuses on stroke, also dementia, and we work, Adam and myself and others work very closely in dementia, which is another major condition that affects many people. It actually can develop after stroke, including haemorrhage. So about 30% of stroke survivors, be it a haemorrhage or an ischemic stroke, go on to get dementia. So there's strong links there. And then a big focus on brain tumours as well, which is a devastating. Brain tumours kill more people under the age of 40 than any other cancer, and that's very under researched. And movement disorders as well, Parkinson's. So we have several areas we really focus on because we know these areas are important clinically. There's unmet needs, and because Manchester is really good in terms of clinical service in these conditions. So that's why we set the centre up, basically. But stroke is a major part of it.
So I hadn't appreciated how centralised this work was. And sure, I'd imagine that you get massive benefits from that. I would have thought one of the benefits you get is you're going to attract good researchers. Katie, you're one of those, and you spent, I think, some time in the States. Can you tell us what attracted you to this, and a little bit about the funding you've received from NKMT and how you're using that, and how that fits with what Stuart's just been telling us about?
Yeah, so for a little bit of context, I actually did my PhD with Adrian and Stuart back in the day, so it's quite a full circle type thing. But after my PhD, I really wanted to go and develop some new imaging techniques to, look at any neuroscience-related, vessel-related disorders. And obviously, most people, when they think about imaging, are thinking about MRI or PET or CT. Whereas there are these really new cutting-edge techniques where you can actually place a cranial window. So it's kind of similar to a window in the sense that you can place this in the skull of a mouse, and it really is like you're peeking in and looking at the brain under its totally normal conditions. You're not really interrupting anything that's going on, and you're just kind of looking in and seeing what's going on. So I was at Yale for the guts of 7 years, and I learned these techniques from a world leader there. And so it was quite exciting when the opportunity came up to come back and to potentially, the microscopes are here, but really kind of reinvigorate this side of research and to put hemorrhage as a key component of that, because really there's only actually one group, one in Cornell, that have looked at hemorrhage using any of these methods before. So it really is quite, you know, a new and exciting way of looking at things. And the other big part that was exciting for me coming back is there's been huge upgrades to a lot of the technology here in Manchester. So, you know, luckily enough, there's been, I think it's a £500,000 upgrade to the microscope that I'm using. And that gives us the ability to look at lots of different cells and how they respond to a bleed. So my interest is to use these windows, look at these bleeds, and look at how all cells in the environment respond to it. And it's really useful to be able to look at all of these different cell types, because, you know, if we only look at the bleed in one cell, we really don't know what the full picture is. Whereas, you know, going back to the window analogy, if you're peeking in and you're looking at someone's living room and you see a teenager cleaning up, you know, you think, oh, he's just cleaning up. Whereas, unbeknownst to you, it could be his mum was over in the corner telling him that he has to clean up. So it's really important that you're looking at all of these different cell types in combination in a relatively, you know, normal, uninterrupted environment. So that's a big part of what I'm aiming to do here. I think it's incredibly exciting time, especially from an imaging perspective at the university. With this upgrade, I've got me, Stuart, and Adrian have got a PhD student who's starting this month, and her focus for the next 4 years is going to be looking at hemorrhage using these imaging techniques. So it feels that, you know, it feels like the beginning of a new chapter almost in terms of this research side of things. And I'm hoping that Manchester is going to be a key spot using these kind of imaging strategies, with hemorrhage being a core component of what we're researching.
So, Katie, maybe that's for Adrian to deal with this, and we'll come to you, Adrian, next about the advances in treatment. But this imaging, is that important for kind of diagnostic or understanding reasons, or can you use it for treatment? I mean, is it? It's almost to what end?
It's more understanding the what's going on with the bleed as the bleed is happening or afterwards. Because certainly, using treatments and looking at how, you know, we'll give these drugs, we'll test these therapeutics and see how the cells are responding to the bleeds. Can we, you know, there are cleanup cells in the brain whose job is to come in and to eat up all the blood. You know, if we potentially have therapeutics that can alter the way that they're acting, that could speed up the cleanup process, or so certainly looking at therapeutics is a huge component to that as well.
Right, which neatly brings us on to you, Adrian. My understanding of intracerebral hemorrhage is relatively limited. I have to say, as lawyers, we tend to deal with ischemic incidents, but not exclusively, of course. But one thing I do understand is that the treatment of these bleeds is really, really challenging. And I think it would be useful, because we're going to talk about prevention. And if you go on the NKMT website, you'll see in bold, treat, prevent, in a particular order. You're the treatment side, as I understand it. Can you explain why this particular condition is so difficult to treat, and the problems you face and what you've been looking at in order to deal with that? Can you help us in that?
Yeah, of course. So, well, I mean, if I think back to when I first started working as a neurologist in stroke, it was around the time the trust was getting set up, it was around 2012. And it was around the time the centralised stroke service got set up in Greater Manchester, so the ambulances will take you to one of 3 open stroke centres, Salford being one of them. And so it was an exciting time, because we were starting to deliver some of the treatments for ischemic stroke. So ischemic stroke causes 9 out of 10 strokes, and hemorrhage about 1 in 10. So patients would arrive at the front door, we'd meet them, we'd rush them off to the scanner, and you don't know whether someone's got a hemorrhage or an ischemic stroke until you put them in the scanner. It's only then that you can tell. And what we used to, something I definitely observed at the time, is that urgency had suddenly stopped when people saw it as a hemorrhage, because there wasn't really much we could do at that time. Now, What happened in 2013 is there was a big trial published that showed if you lowered blood pressure really quickly after someone comes in with a hemorrhage, that it can reduce the risk of any further bleeding happening. And that further bleeding happens in about 1 in 3 people, and when it does happen, it happens really early, so it happens in the first few hours, whether in A&E or they've just gone up to the ward. So around that time, when that trial had been published, we kind of thought, well, if we did all of these things really quickly and really well when patients came into A&E, it would make a big difference. So we focused on 3 things, which was if they're taking blood thinners, which about 20% of people are, and they come in, things like warfarin or other blood thinners. So if we give the antidote for that really quickly to reduce the risk of further bleeding, and if we do this blood pressure thing and lower the blood pressure very quickly. And finally, some patients will have an operation to remove the hematoma in the brain, and that's about 5% of the people. So we also put some referral pathways in, so we referred people really quickly. So those were the 3 things that we put in place. And we monitored what impact that had on survival after intracerebral hemorrhage when we first did it, which was in 2015-16. And what we found was that it reduced deaths by about 1/3 after intracerebral hemorrhage, and we were actually really surprised that it did, so we're obviously delighted. And so those kind of things have become part of what we do, and we've tried to expand that project up. So we've scaled it up across the north of England and just finished that. We're trying to persuade NHS England to let us take it nationally and to do that nationally. But that's really only targeting one little bit of intracerebral hemorrhage, which is just that further bleeding. So the things Katie was talking about, trying to reduce the damage that the blood does to the brain around it, we don't have any specific treatment for. And there's a lot of work to be done with surgery and whether surgery would be beneficial. So this year, quite excitingly, we had our first positive trial of surgery for intracerebral hemorrhage, which showed that a special sort of keyhole technique did improve the outcome for selected patients. And there's a lot of trials going on at the moment, so we might see a bigger role for surgery in the future. So it's changed a huge amount, I think, in the last 10 years, but there's still lots to do.
Listening to all of you together, it sounds as though there is a collection of expertise here in Manchester. Adrian, what you're talking about is pretty cutting edge. Is there any prospect of being able to roll these sorts of things out, across the country? Because presumably there just isn't a level of expertise.
Well, I mean, I think our experience so far is that the infrastructure's in place from looking after ischemic strokes. So these patients get met at the front door by experts, stroke clinicians now. And they do these things, so they will reverse blood thinners, they will lower the blood pressure, but just not that consistently or effectively. And so it's actually, it's fairly simple stuff that people are doing, it's just making sure you do it really well every time with everybody. So we've used quality improvement techniques to try and deliver improvements in care when we have done this project. So there's a lot of strain on the NHS at the moment. People have got sort of limited resources and time to do things, but we have been able to make quite a difference so far, and hopefully to take that further.
And is there any, is there any guidelines or published guidelines that people in this situation can go to, whether it's or locally based guidelines or anything like that?
Yeah, so there's a national stroke guideline which was updated in 2023, and that has these things in it. So it has reversible anticoagulation and blood pressure lowering. There's also a NICE guideline as well, which has the things. Right.
In all the medico legal, all the lawyers in the room, the alarm bells will now be ringing, because that's where we tend to go to first. So what you're doing is actually, it's not just a kind of an esoteric thing that's going on in Manchester. It is actually going to have quite wide-ranging consequences.
Yeah.
Which sort of, I suppose, Fiona, bring us on to where we are now and what the Trust kind of wants to do moving forward. Because you're very much, from what I can tell when I look at your stories and the website and the information available, you're focusing on results, aren't you? Can you just, we had a quick chat this morning about that and what you're trying to do and why we're now going to look at hypertension and what we'll talk about in a minute.
Yeah, absolutely. I mean, obviously, as you can hear, the research is involved massively. There's an awful lot more work to do, as they've all alluded to. And I think the point with that is also that it demonstrates, once funding comes in, they can do more, they can see more results. And I think that's where it's really key, and obviously your guys' support is helping that too. So, and obviously we focused on the treatment side of things for the last 12 years, and we got to a point where we actually had said for 12 years the prevention and treatment of brain hemorrhages, but the truth, we were never really looking at that word prevention. And it's great to be able to treat somebody once they've had a brain hemorrhage, but even if they've had it, the likelihood of them surviving and if they get treated, their life's going to be significantly affected. So we all know in every single capacity that prevention is better than cure, and we really wanted to look for a way of thinking, how can we prevent these from happening, but also in a way that's really accessible, that people can tangibly take away and do. And I had many conversations. I asked Stuart for a number of things, like reading through papers and, looking at it. Blood pressure just seemed like this really low-hanging fruit, and I was having conversations with Adam, and he'll share more about hypertension in a moment. But the reality is that a lot of people do have high blood pressure. The reality is also that a lot of people are undiagnosed. They're walking around with this massive potential problem of having a bleed on their brain. It just seemed to me like a really obvious thing that we can do it to actually stop these from happening in the first place. Because whether we prevent them or we treat them, our mission as a charity is ultimately to stop lives being affected, deaths happening, families being affected, from our point of view, by brain hemorrhages, because they are so incredibly devastating. It's very much a line in the sand of the before and then after of a brain hemorrhage, and it affects families and communities. So, as I say, if we can prevent them before they happen, then that's helping all the treatment as well. They can think about that too. So that's where this work has really evolved from as well, and that's, as I say, where Adam comes in too, and that's where this prevention side of piece that we're working on is now really kind of moving forward at quite a speed too. And we're really kind of driving this message, because whilst this message is already out there, you'll see it in a lot of places. We feel that it's very much funneled towards an older generation. It's kind of seen as an older person problem, or also a problem for people who are overweight or unwell, or just not looking after themselves, which is not necessarily true, and we want to change that narrative. So we'll be doing a lot more around speaking to younger people and educating more from a younger age too. We'll touch on that a little bit later. But just it's basic education that people need, and that's where we're going into companies to talk about it, doing events like this, getting out to the streets of Manchester or wherever, to just educate more people on the importance of very simple check, and that's the point. It's a very, very simple check, which will be life-saving.
Right. Well, coming back to Stuart in a moment, we talked about low-hanging fruit, and I'd just like your views, just sort of flagging this up so you kind of think about it rather than later. Your views of what the Trust has done in the sense of focusing on treatment, focusing on understanding the pathology a little bit better, and prevention. And I'd like your thoughts about that in due course and where we might go. But before we do that, Adam, you work with the hypertension service, don't you, which has a worldwide reputation, as I understand it. Blood pressure. This is what it's about. So can you explain to us why blood pressure is so important regarding ICH, so the hemorrhages that we're talking about?
Yeah, thanks. Thanks, Adrian. Thanks for organising this. It's a real pleasure to be here today. So, I'm Adam Greenstein, and I work at Manchester Royal Infirmary and the University of Manchester as well. So I think the first thing to say in this context is, as you've heard from Adrian, you really don't want to have high blood pressure in the context of that bleed on the brain, because the outcomes are worse, and you're also you can then have a rebleed, and your recovery, I think, is worse as well. And high blood pressure is something that I think that we'll talk about a lot in communities, and you hear it on the news a lot. But it's one of those things that just seems to be very easy to ignore, because it's always just another problem that we have to think about. And this is why we call high blood pressure the silent killer, really. Because we all have a level of blood pressure in our bodies. This is how we stay alive, because we need a certain pressure within our arteries, that's your blood vessels that come out of the heart, in order to perfuse all of your vital organs. The problem arises is when that pressure is too high. And the problems that you can get from having high blood pressure are really quite, terrifying, because we're all sitting here and I presume the majority of us are all healthy, but it can cause incredible problems. And the brain is really the most susceptible organ in the body to high blood pressure damage. And as you've heard, in the context of brain hemorrhage, which is this catastrophic condition, which, although there have been wonderful improvements, it's still one of the worst things that can happen to an individual from a medical perspective. High blood pressure is the main modifiable risk factor for this condition, and yet it remains one of the easiest things to check for. So you can go to your pharmacy now. There are apps on your watch. You can go to your general practitioner. You'll see a physician associate, see one of the practice nurses. And high blood pressure doesn't just cause brain hemorrhage, it also causes memory loss and dementia, causes the ischemic stroke, which is the furring up of the arteries and then the clot lodging in the brain as well, causing brain damage, as well as causing all of the other problems. I'm very happy that we've got some of our colleagues here from the world of optometry. It can cause visual problems, kidney problems, and problems in the heart as well, of course. So it's really fantastic to be working here in this context, because it all feels so joined up, because what happens in medicine when we don't work well is that we work in what you would call a silo. I would be working in blood pressure, and Katie would be working on looking at the effects of bleeding on the brain, and Adrian would be working with patients who have brain hemorrhage. But the difference that now became lost trust is enabling for all of us to work together on this, to look at the treatment and the prevention as well. And one of the things that Fiona and I have been really excited about is looking at high blood pressure through the life course of people, because a third of us have high blood pressure. It's really quite scary that so many of us in the room, I think there's probably about 30 of us in the room, so 10 of us here, have got blood pressure, which will cause, over the course of your life, damage to your brain. And the treatment is really very simple. We've got fantastic drugs that cause virtually no side effects. And even if some of them do, you can then rotate through to taking other ones. And the person's blood pressure is a very useful barometer of your health. So, for example, if you maybe are eating properly, don't exercise, maybe taking too much salt, then your blood pressure will go up. And that puts you at risk of not just having things like brain hemorrhage, but doing worse if you did have one. So I think it's just a fantastic opportunity to get people to look at their overall health and try to improve things.
Can you help me with this, Simon? Just curious. So you're saying that high blood pressure is an indicator of general health. It contributes to various systemic problems, diseases, and also it hampers your ability to recover, and the outcomes are worse. With regard to this particular condition, hemorrhage, can you explain in really simple terms how the high blood pressure is actually a predictor or increasing the risk of those hemorrhages happening? Is that right? Is what I've just said correct?
I'm going to hand over to Adrian.
Excellent.
This is his area.
Brilliant. That's why we've got the panel. That's what it's all here. Right, Adrian, why is increasing your blood pressure making this condition more prevalent and putting you at risk of it?
Yeah. Well, I'm going to just echo what Adam said, that it really is the biggest risk factor. I've just been working on a fact sheet for the World Stroke Organisation and looking at global data about risk factors. And in almost every single setting, high blood pressure is the runaway leader in terms of risk factors. So it's definitely right out there. So, I mean, what it does to the small vessels in the brain is it causes these changes, which we call arteriolosclerosis. But basically, it sort of hardens them up and makes them fragile. We do know that there may be a bit of a surge in blood pressure before the bleed happens, so there's some data that suggests that. But ultimately, that weakened vessel will then rupture. It bleeds into the brain up to a point and then stops. I talked to you before about how the bleed might continue in hospital when we try to prevent that. But obviously, that initial bleeding's happening before someone gets to the hospital. And so that's what's going on.
And so what age groups are you seeing these changes? I mean, if someone's sort of 40 and they've got high blood pressure and they need to do something about it, how is that going to be an advantage of these reversible, or just stop them, these vessels deteriorating?
Well, it's unfortunately not uncommon that we see people relatively young who come in with a brain hemorrhage due to high blood pressure that's just gone completely unrecognised. And you see changes in other parts of the brain which have arisen from having high blood pressure. So we obviously then want to treat it long term, and that will sort of help to slow the process and reduce the risk of hemorrhage in the future.
Okay, so it's a slowing of the process rather than a reversal of the process, so bringing the blood pressure down, slow the process as opposed to...
Yeah, and then people who have had a brain hemorrhage due to high blood pressure have about a 1 or 2% risk of having another one each year if you keep the blood pressure low. But if you don't, obviously that can't.
Okay, so Stuart, you nodding, and I know you're at the centre of all of this. I mean, what are your thoughts sort of moving forward with Fiona's focus on hypertension?
Yeah, no, I think it's fantastic. I think I would say this in every degree, right? Stop. Something not happening is better than happening. Okay, prevention is a major focus, and actually for Manchester. As you probably know, Manchester was the first country in the world, or city in the world actually to have a joined up healthcare system in terms of social and medical. And the big focus is on prevention. And cancer has been really successful. Cancer has made massive breakthroughs in terms of prevention and early detection and prevention. Because of course, if you stop something happening, it's the best thing to do.
Well, I was sent my screening pack yesterday.
Yes.
Well, God,
no, it's amazing. Right? No, it's amazing.
And in fairness, because my father's gastroenterologist, so I kind of knew I should do it.
Yeah, no, absolutely. Cancer have led the way in this, right? Really about trying to get it identified as early as you can if you're going to have it. And it's no different here. It's exactly the same thing. I think amazingly, despite the fact the brain's the most important organ we have, we've sort of not looked after our brains. So I think this narrative that Fiona and Natalie Moss are developing is really fantastic. And we are now establishing, and I think Adam referred to this, and the reason we set up the Jeff, as we referred to it, was really to bring people together. Was to say, well, okay, we've got this excellent clinical service, but actually many of these people don't talk to the scientists who can actually, like Katie, doing the science to try and understand what's happening with the brain. Ultimately to bring it all together to get much more rapid development of treatments and pathways. Adrian talked about the pathway, the ABC pathway is referred to, which actually it's actually a relatively simple concept, right? It's nothing really high tech. It's just making things happen quickly, more efficiently, and the right things that happen. So that's why we established Jeff, and I think that's the exciting thing about it. And the focus now is around brain health. So we're beginning to create a narrative, and Adam and myself are working on an idea of a brain health centre, which will be focused around dementia initially. And it's about brain health. And it's about the messages around brain health, okay? And that's largely about prevention. It's about preventing the things happening. Because the reality is, and sadly you're absolutely right, even if we're the best, we can do the best science we can in the world, but if you have a major bleed in your brain, actually your recovery is going to be limited. You know, at best we'll reduce the impact so people get a quality of life back. But I think it's probably have to be honest here. I think it's unlikely you're going to go back to what you were before, because there will be the very fact is you lose as soon as that blood hits the brain, some brain cells die, and at the moment we have no way to regenerate brain cells. People are trying, but it's very challenging.
Okay, so I'll ask Fiona to explain what she's doing with regard to education and access to blood pressure monitoring, which Fiona, if you wouldn't mind picking up in a second. But before we do, Adam, what are we talking about in practical terms? Just in very simple terms, what as it happens, I know what my blood pressure is. I didn't know for about 5 years before last week, but I do know now, and that'll be okay. But what in practical terms do I need to go every 6 months? Do I need to do it every month, every year? What are we talking about?
I don't know. Let's bring in the audience.
Good idea.
Be quiet for far too long. Okay, so sorry to do this to you. Please put your hand up. No, sure it's. Yeah, so you can see probably between a half and a third of people. So, I mean, obviously this is my job, but I think that a lot of people that here are probably quite health conscious. So you may know what your fitness is like. You may be conscious about what you eat, for example. You may be conscious about how much salt you take, or how much you exercise, or how much alcohol, or whether you smoke or whether you don't want to smoke. You may have these same thoughts about your children as well, whether they're healthy or not. I think for us, the general emphasis is that blood pressure should just be an extension of that. So if you think about, I'm going to go and do some cardio now, like what you mean by that is we'll probably do some exercise, which is good for your heart. We don't really see the brain any differently. People think about the brain as an organ in your body which is mostly nerves, but that's not actually correct, because there's far more blood vessels in the brain than there are nerve cells. In fact, each of us has got about 500 miles of blood vessels in our brains. It's an incredibly complicated and vascular organ, and all of these arteries here are basically facilitating the process of brain health so that the nerves can work properly, so that you can, for example, understand what we are saying. And so, if I ask you, say, for example, how often do you think about your heart health?
I'm quite paranoid about it, actually, because my dad had a really nasty heart attack at my age, and my wife's mom had a really nasty heart attack about my age, and for that reason, and also I've got AF, and my brother's got AF, and so I go and see a cardiologist, and that's why I know what my blood pressure is.
Exactly, this is the thing. So blood pressure does seem to be the missing link in people's lives. It's because it's something that you can almost forget about. And I would say that you've got exactly the right approach to this, is that most people don't know what their blood pressure is, but could check it, and it could probably be the easiest thing that you could do. For example, you talked about having an irregular heart rate with atrial fibrillation or AF. That's quite difficult to pick up with. Your blood pressure is much easier than that to do. So, depending on how often you want to check your blood pressure, that will be determined by whether your blood pressure is high or not. So, for example, if you check your blood pressure, and I should stress that you should check it properly, otherwise you get a falsely elevated reading. But if you check it properly and it's normal, you can probably forget about it for 6 months. And then if you check it and it's high, and so by what I mean is high is if you're checking it at home, you take the blood pressure cuff, you take it before you've had a coffee or not after a big night out. something, not when you're too stressed. And if you take it 3 times, with a minute in between each time, and then check which arm is higher and then use the higher arm. If your reading is below 135, you're basically in the clear. And that is something that you could do. And it's almost equivalent to not smoking, which all of us will be thinking, like, well, I'm not going to smoke because that's bad for me. And if you do smoke, you might try stopping smoking. And the irony is that people will try to do things which are bad for them with a lot more effort than they'll actually check their blood pressure. And the blood pressure represents the composite endpoint of all of these risk factors that you can spend a lot of time trying to address. It's really easy.
The thing you said was, it's a hell of a lot easier to fix than, say, giving up smoking, isn't it?
It's so much easier. Exactly. And yes, so yeah.
It's a no-brainer.
It's a no-brainer. And I think that this is the sort of thing that Fiona and I have been talking about. It's a barometer of your overall health. And I think it's so common now, because it affects between a quarter and a third of the population, that it's almost making it easy for people to check. It's almost a bit like a gift to people. It's like you take control of your own health. Don't leave this very important factor about your long-term brain health to the doctor. Oh, I'm not going to check it because I'm going to have a check with my doctor, my GP, when I'm 50, and he'll check my blood pressure. Because if you've had high blood pressure from the age of 35, that's 15 years of damage to your brain. and that's, like Adrian was saying, he sees people who have a brain hemorrhage who are 40. And so you check it early on and you treat that risk factor and you dramatically reduce your risk of having these catastrophic illnesses. And so it almost becomes a concept that is kind of pushed away from the medical profession, and it becomes a responsibility, a personal responsibility, along with all of the other things that we do.
And certainly that fits with society, it fits with the law. We know the lawyers in here will know about developments and things like consent and
Yes.
Autonomy of patients and that sort of. So it's absolutely the way we're all going as a society, not just medicine. But Fiona, just before we open up to some questions, the last few minutes that we've got, pull all this together then. So 2025, what's the plan? Because you know all of this stuff. What's the plan moving forward?
Yeah, absolutely. And I think, as Adam's just said and Adrian said before, it's not an old person's book. And that's like a big thing that we're trying to push. And rightly so to what Adam was saying there, people do take care of their health. They want to take care of their well, most people have some sort of wearable, an Apple Watch, a Fitbit, a Garmin, whatever. They're really interested in it. They're wanting to do things. And this is such a simple, accessible thing that people can be doing and can be checking. So it's been pushing more of that message. But as I said before, it's very much also about educating from a younger age as well. So one thing that we really want to do is introduce this topic into the curriculum in PSOT sessions, which is conversations that we're already beginning to have as well, and looking at how we could potentially trial that out into certain groups next year. And educating children from a younger age, not to scare them in any way, but to give them this information and to be aware of their blood pressure and aware of, again, that proactivity of taking responsibility for yourself and checking at home. Whilst you can get it checked at a GP or whatnot, you can also get it checked at home. You can actually get it checked today. There are some blood pressure monitors at the back if you wanted to. But so that is something that we're looking for in 2025 and looking to, we'll need all the support we can get with us contacts or, resources as well with that too. And also in terms of what we have already been doing is getting out onto, whether it's the streets of Manchester, up to universities, and just having stands, having awareness days, allowing people the opportunity as they're passing by to check. When we've done it in central Manchester, for example, we've, depending on the day, checked between 300, 400, 450 people's blood pressure on the day. So if we can roll that out and do that 3 times a month across a year, you know, we're talking about sort of 12,000 people a year that we're checking. You know, that's 2,000 people that potentially we could be diagnosing who didn't know they had high blood pressure. So it's looking at how can we expand our team so that we have the capacity to do those things as well. There's an awful lot beyond that we want to do, but as a charity, it's about growing, it's about being sustainable, whilst committing to the prevention campaign, also continuing to commit to the treatment and the research as well. You know, as I said before, this is very much a 2-pronged approach about the bigger mission, which is ultimately about stopping brain hemorrhages having such a devastating impact on people's lives as well. So they're 2 of our major things that we're going to be looking at next year. And I'm sure, no doubt, there'll be more things to come as well. So,
right, so we've just got a few minutes left. I don't know if anybody I've got some really basic questions that I want to ask, but has anybody got any questions they want to ask?
Well, if you took 100 people with high blood pressure, how many of those people would have an underlying sort of thyroid condition or diabetes that would be behind it? How many would need medication, and how many need to stop eating as many chips?
And how many would you need to stop a brain hemorrhage?
Or in order to get the blood pressure down, what sort of proportion would need intervention? What sort of proportion is a lifestyle issue?
Well, let's start with brain hemorrhage question, because that's why we're here. So, again, I'm going to ask Adrian to talk about what kind of benefit you get from reducing your blood pressure in terms of brain hemorrhage.
Yeah, okay. Well, I mean, I think I'm much more familiar with secondary prevention, which is what we do when somebody's had a brain hemorrhage, and I think it reduces the risk by over 50% of a recurrent hemorrhage. Obviously, there are people who've already had a hemorrhage, selected high-risk group. We will often screen them for secondary causes, so things to do with your glands or your kidneys or something like that. So we do look for that, but often you don't find that. The majority of people just have high blood pressure. And I guess in terms of the wider treatment and lifestyle interventions, that's back to Adam.
Yeah. So, you'll massively reduce your risk of having a stroke and brain hemorrhage or reducing your blood pressure. It's the most effective, unless there is something like what Andrew was talking about, which is atrial fibrillation and irregular heart rate. That in itself is caused by high blood pressure as well. For the majority of people who you would see first off, if your pathway towards getting treatment for high blood pressure, so if you checked it and it was high, you would then go and speak to a pharmacist now, because they're able to treat it and give you lifestyle recommendations, or your GP. And what they would then do is that they would then do a 24-hour blood pressure recording for you to confirm or refute the diagnosis. So just because you know what it is at home, you know, it may be on borderline, so you have this sort of awareness, then you want to get the diagnosis. Like Adrian was saying, the vast majority of cases, we don't find an underlying secondary cause. Although on saying that, 70% of all new diagnoses of high blood pressure are due to weight and diet. And you know, unfortunately, we're bombarded with access to cheap, unhealthy, high-fat and salt-laden food. And salt is a bit like a tablet to raise your blood pressure. You know, we talk about tablets to reduce your blood pressure. This is like taking a tablet to increase your blood pressure. Not in everybody, and the majority of the people have a normal salt intake. It doesn't affect your blood pressure that much, but what we tend to do is when you have a diagnosis of elevated blood pressure, the first thing that we would do for everybody is to try and get people to improve their overall lifestyle. Exercise, alcohol, salt, diet, smoking, because for the majority of the people, it will bring the blood pressure down. And again, yes, you can treat this, but to a degree, comparing those two is a bit like comparing, a curative procedure, which is the lifestyle approach, to a sticking plaster, which is the drug. Your body will thank you in the long term. One's body will thank you in the long term for making these changes, which will improve your overall cardiovascular health, and that's what we're talking about. We're talking about the arteries of the brain, which, as Adrian was saying, they become brittle and fragile and leak and then cause strokes and brain hemorrhages. High blood pressure does that to you, and what we know is that when you have it in the context of unhealthy lifestyle, obesity, smoking, salt, etc., you're more likely to have things like stroke. So you can have high blood pressure, or you could have worse high blood pressure, which causes more damage to target organs.
Well, good question. We got any? Yes.
You mentioned, if I understood you correctly, that there may be a link between increased blood pressure and dementia. Is that something you can tell a bit more about? I find it really interesting.
So, yeah, like I was saying, so the brain is, I've got a slightly kind of slanted opinion on this. Like I said to you, the brain, we think of it as a bundle of nerves. It's a bundle of blood vessels which enable the nerves to work properly. Dementia is almost a bit like brain failure. And almost everybody who has memory loss and dementia has got some issue with the blood vessels that supply the brain. And so there is a very, very clear relationship between your level of blood pressure and your memory. So the studies are absolutely unequivocal. Your blood pressure in your 50s determines your memory in your 70s, period. And that is what I use in my clinics when people are not keen on taking their blood pressure tablets, because it's not particularly well appreciated. It's only been known, I suppose, really from a vascular perspective over the last 10 years or so. Every time we do a study, we just see these incredible benefits on the brain to treating blood pressure. So, and I know that half of my patients who have medicine for blood pressure don't take them. The reason they don't take them is because of what we talked about earlier. It's the silent killer. You won't have any symptoms when you find out you have high blood pressure. A doctor or a pharmacist will give you a medication which will make you feel ill. So you go from feeling happy with no symptoms on a Wednesday to then knowing that you have high blood pressure and feeling nauseated on the Thursday. And then you think, right, well, I'm not doing it because it's just easier to park it and not think about it. And but the tragedy of that is that we can treat it, we can switch people from drug to find something that suits people and we can protect their memory. So yes, very clear, very good question. Again, there is very clear.
I wish we had time for more questions. I've got probably time for only one more, unfortunately. Richard,
You mentioned people wearing smartwatches. Do you have a low resting heart rate but high blood pressure? Or is the heart rate a tell, or can you have high blood pressure even though you have a low resting heart rate?
Yeah, the two are connected, but they can coexist. So what tends to happen is that as you exercise more and become fitter, your heart rate will go down and your blood pressure will go down. But part of your blood pressure is determined by how much blood is pumped out from your heart. So if you have a slower heart rate, then less blood is pumped out.
we'll squeeze one more in. Is everybody got a... Yes.
Very quick one. When somebody's had a brain hemorrhage and you said you lower their blood pressure, what do you lower it to?
So the trial showed that you had to be within 6 hours of it happening. So we don't really know how well we are. That's the first thing to say. But as long as it's above 150, the trial aimed to lower it to below 130 within an hour. That's it. And use intravenous drugs to do that. You're supposed to then keep it there for the next week. Ideally, long term, you get to sort of secondary prevention. So it's a very quick lowering. It's actually quite hard to do, well, which is why I think we needed all these sort of quality improvement approaches to get it doing it quite consistently.
And you're always looking at the systolic.
Yes, it was based on the systolic, yeah.
What percentage difference did that make in terms of outcome when you did that successfully? Would it sort of halve the risk? Or?
Yeah, well, I mean, that's so in the trial that showed it worked, it had quite a modest benefit, actually, but so it didn't reduce mortality in the trial, but it had a modest improvement in shifting disability. So I think we actually saw a much bigger benefit when we introduced it as part of a package of care. I think there's probably some synergy between doing all of it together. And we also really interestingly found a big knock-on effect of doing the project, which was that clinicians became much more optimistic about this group of patients, so they got a lot better supportive care as well, markers that further down the line things improved. So I think there's a synergy between components of what we call the care model. So it's the three things that we did, and also some knock-on effects.
No, keep going.
Did that help? Was I don't suppose any therapy outcomes were looked at as part of that trial in terms of where
Yeah, so obviously mortality is really easy to collect.
Well, yeah.
So we didn't have the resources to collect disability scores. So there has subsequently been a big trial of a similar care model done internationally, but most of the patients were recruited in China. It was really similar to what we did. And they did collect the 6-month modified Rankin score, which is the death and disability score combination. And they did show a definite benefit in terms of reducing disability in that trial. And if we are able to scale it up across the UK, then we're going to use existing data to measure that essentially by looking at how much time people spend at home in the 6 months after their stroke, which is a reasonable surrogate measure of disability, but again, easy to collect from administrative data.
Right, I'm conscious that it is Thursday morning and people have got to go to work. I'd love to hear loads and loads more questions. Can I just finally thank all the panellists and indeed all the partners for coming to this meeting. And Fiona, can I just make one observation, because I'm absolutely new to all this, as you know. It is an absolute demonstration to me of what I've always believed: if you can get specialist groups joined up thinking, you can move these debates so far, so quickly, so effectively, and it's been an absolute demonstration of that to me this morning. So absolutely fabulous and well done. So we could also thank each other in the usual way.